the next 45 minutes or so, we'll be hearing from some of our colleagues talking to us about what their roles and responsibilities are within their organisations around health equity, health disparities and health inequalities. And we want to then sort of come away and have a conversation, think about how best research skills and expertise can support some of your work, so that we are all collectively working within our local place and offering a research solution and some understanding to some of the work that you're undertaking. There's a fair few of us, and I know quite a few of you, but because of with it time limited, it might be helpful if you just want to introduce yourself in the chat so that others have got an understanding of who's here. We've got colleagues from the ARC, as I've said. We've got colleagues from OHID, and they'll explain and define that. We love an acronym in health and care, don't we? You know, ARC, OHID, PHE, NHS England, etc. We've got colleagues from NHS England. We've got representatives and colleagues from our local integrated care systems and healthcare partnerships. So I think in the round, we've got quite a good representation to sort of kickstart and begin these conversations, to think about whether there is an appetite actually for this community of practice. You know, we get invited to quite a lot of network groups, you know, things that we sort of can begin to join the dots up. So I think my aspiration for this next sort of 45 minutes is for one to think about whether this group, a community of practice around health equity with some support and expertise from applied research, should we start it? Should we begin to develop a group? Or from conversations, is there something, some groups, some networking opportunities, some place in your local systems where you think a research lens might be appropriate, but it'd be best for us to connect with you as opposed to establishing a new group? So just things to think about in the round over the next 45 minutes or so. So as I've said, we've got a lot of the system in the room or on Teams, and if you begin to start introducing yourself, I think that would be great. So our first presenters, if you like, very grandly, is Katerina and Mark. If you'd like to share your screen, please, and then you can talk to us about the work that you've been doing in ARC. Thanks, Mark.
Right, Katerina, you're ready.
Excellent. So, hello everyone, welcome from me too. So you've heard a bit about ARC from Paula just now. Mark, if you want to move to the next slide. So ARC North West Coast, along with this, stands for 70 member organisations, essentially comes with a mandate to focus on addressing considerable health inequalities across our region through delivering high quality applied research and implementation projects. And that comes with the short-term objective to facilitate integration of equity across all of our work, a medium-term objective to evaluate our themes on embedding health inequalities, and a longer-term objective to have a legacy of a coordinated, well-connected network of empowered organizations and communities with the skills and the confidence to co-produce work relevant to local needs, targeting health and care inequalities. So to achieve this long-term objective is essentially to mainstream equity, and that is to make equity a systematic consideration in everything we do. So mainstreaming is both a state and a process of change. Move to the next slide. So trying to develop a map of how we can bring about that culture change across ARC North West Coast, we've developed the HEMS, which is short for Health Equity Mainstreaming Strategy. And that is a strategy whose ultimate aim is to become dispensable as synonymous to an integrated equity lens into the procedures and practices of each member organization and at all stages of each research project, of course. So health equity, especially after COVID, is a top priority for most organizations, if not all. And we tend to talk about ARC as a homogenous thing, but we do know from experience that organizations will be at different stages in their health equity journey. And that also means they'll be at different stages between departments and teams in each organization, or just varying by project. So as a team leading on equity work in ARC, we've at times been approached in the past and asked for help with equity, to which we respond, great, what with exactly, or where are you up to in that equity journey? And the answers we get are not as straightforward. Sometimes we get, oh, don't quite know, which makes sense. I mean, one cannot know what one doesn't know. And then in other cases, we'll offer some training, we'll do some workshops, plan something to support the team, but then we'll kind of find out that there was a misinterpretation or a misjudgment of how further along on that equity journey a team or an organization are. So with applying the equity lens to their work and research. So quick and dirty response we had to those needs was to develop an easy to use screening tool that can be applied to specific projects or used by whole teams. And the interactive version of it will ask just 4 questions, and then it will show you how equity cool your team or your project are based on this thermometer that you're seeing on your screen now. But as said, I mean, sometimes equity coolness will vary even within a team based on a project. It will vary between organizations, and it may also be the case that it's just not applied throughout the entire research. So a common example tends to be a lack of equity in the plan dissemination activities. Or it may feature in one of your policies without being a common thread throughout all of them, which is what we would ideally like to have. So from an ARC perspective, we are here to help our member organizations progress on their equity journey. But just to be able to do that effectively, we need to have a common understanding first of where they are on that journey now. And actually, that's not just for one member's sake. Progress does stall if each organization has to learn through trial and error rather than learning from each other. So as a next step to the screening tool, if you want to move to the next slide, please, Mark. As a next step to the screening tool that will be published soon, so that was a very early draft preview, we set out to look into the public information available through each organization's own website and try and gather how equity cool they appear to be. Now note, this is appear to be because this is just based on their public facing comms. That might not necessarily be where they really are. So we used some keywords like equity and disparities, and we conducted a very simple search of the websites, extracting key documents like EDI strategies or annual reports and basic web pages like About Us. And we aim to do a very crude check of how much these include, if anything, around equity. And eventually the work leads to a map that can be reconfigured to be organized around different types of sectors or different types of organizations or different document types. And it can be as high level or as granular as we need it to be, which then allows the allocation of organizations to a level of equity coolness according to our thermometer that you just saw. And there are essentially multiple outputs from this mapping exercise, from numerical tables and word clouds and word trees that you'll see in a minute. And we think they can all offer useful insights and are definitely conversation starters. And that is what we aim to do with this. So we want to get involved in conversations with yourselves about your own organization, your team, your research project, the network you belong to, or just the wider community, and use it as a tool in the process of equity mainstreaming. So in case you thought this was the map, sorry, disappointing, we haven't been that creative, not just yet. So what we'll do now is I'll hand over to Mark, who is a real brains and wizard behind our mapping, and he can give you a closer look to what the real outputs look like and explain also a bit more about the methodology behind this.
Thanks, Katerina. So this is a work in progress, so there's nothing complete yet, and it needs to be guided as well. So it's like any of these sort of types of work. You start off with an idea, but actually what happens is it develops over time. So we are sort of taking that very qualitative approach of being sort of, we'll review it and we'll come back to it and then redo something and keep moving through the process. So what we've done to date in terms of the methodology around this initial scoping exercise is we first looked at all the ARC members in the Northwest Coast, and we've sort of grouped them by an organisation title because it just makes it nice and easy. I mean, I know all the organisations, I'm looking at them individually, but in some ways to look at what's happening between different types of organisations within the ARC. So what I've done is I've looked at each member website, and as I said, that's in progress. We've used their own internal search engines to look for these keywords, and the keywords we've chosen are inequalities, equality, equity, disparities, and diversity. And Katerina knows why those words have necessarily been chosen, but I think they broadly give us an idea of what the keywords may be. There are multiple other words, but I think we just wanted to keep this nice and simple. So we're using NVivo as a sort of a software that allows us to capture web pages, store downloaded reports, and then it allows me to code and explore those documents and what the information is in with them. So that allows me to do that. So part of the process is coding the documents. So we've coded them around the different types of, whether they're policy documents, the reports, the strategies, whether it's just a web page. And within each of these, there's some subcategories as well. The next bit is I've explored some of it, and that's using text searches, looking for keywords. And then there's this word frequency. It allows us to sort of create some little pretty pictures, but it gives us a sense of where everybody's at. And then there's this sort of third level, which is actually mapping it and seeing whether these maps actually will help us in terms of that thermometer or that temperature that we were looking at earlier. So where do people fit? This is as at the moment, this is the ARC membership. There's two numbers. One is the total numbers, and the smaller number is the number that I've actually looked at. So there are 5 charities that are within the ARC membership, and I've looked at 3 of their websites. I've still got 2 to look at, and that goes the same through the list. I think what this shows us is this is the average number of hits within these different groupings. So if you look at some of the keywords, you'll start to see that certain keywords are sort of hitting the level. So if we go across everybody, diversity is one of those words that seems to be on everybody's websites, whereas disparity is on very infrequently we see it. But I gather disparity is a little bit more of a newer term, so maybe that's partly what's being reflected in it. There are terms like equity and obviously equality, and you can see it's different for each of the different groups and the different organizations. The other side of this, it just shows you how many hits. So trust, there's quite a lot of hits, and universities, but when I go into the networks and when I go into councils, it's starting to get less number of hits on their websites. Now, that doesn't necessarily mean they don't have the information. It's just maybe that's just doesn't sit within all the documents, etc. So the next bit with that was, what are the documents we're getting? So one of the questions I asked myself is, actually, should everything be looked at, or can we almost narrow down where the information that we're trying to measure the coolness of the HEMS part of this is, do we need to just look in certain documents? So the first thing is actually, what sort of documents are we getting out? This is the charity map. So you can see there are reports, there are outcome documents, which are case studies and some research findings. There's a lot of EDI, equality, diversity, inclusion documents. There's web pages, and within web pages, there are blogs, events, FAQs, information guidance, news, etc. And what we may decide is that news is just, well, that's what they're just saying. So actually, that doesn't really mean much. So we won't explore news documents much more than, well, it's just been reported what they're doing. If we look at the trust mapping, you can see there are more documents to start with that have those keywords in it. And then there are obviously certain documents that they have to produce as part of their policies within their work frameworks. And so that's why you see things like the Workforce Disability Equality Standard, and also the Race Equality Standard as well. So there are certain documents, but we get very similar documents to what the charities are doing as well. So there is some crossover, but you can start seeing between 2 different types of organizations within ARC that their picture of the types of documents that have the keywords that we've looked for are actually quite different. And so that doesn't necessarily mean that one is better at it than the other, because actually you might have lots of documents with it, but may still be at that cooler level or that warmer level in terms of the thermometer. If we look at the next bit is actually looking at the sort of the top 20 words that are in those documents. So again, this is sort of extracting the documents and then looking at each of those documents and going, actually, can I find what are the key top words? And the boxes sort of signify the number of times the word is mentioned. So if we look at charity, equality, diversity, and inequalities are the top 3 words that are produced, which is slightly not a surprise since we've chosen documents with those. But you don't see any, so you don't see the other words are in there. And then the next ones are sport, inclusion, and policy. And then you can go through all the different bits. When we look at the NHS, with the similar tree map, equality and diversity are there, then there's inclusion, and then inequalities come into it, and then workforce and health. So you can see, well, it's not surprised that health is a word that crops up in a NHS trust document, etc. So this just gives us an indication of, okay, so do the documents contain the information that we're looking for? And actually, I think most of them will have it. There's another way we can look at it, which is a slightly different way, but a slightly prettier way, I think, is to look at it in terms of word clouds. So word clouds are looking for similarly the number of times a word is mentioned, and then they produce this sort of pretty picture that shows you that the keywords again are there. But what it shows you is where the other words are sitting. So equity and disparities are two of the keywords we look for, and equity turns up, but it's quite low down. It's there hidden in the corner. But disparities is not actually in the top 50 words within the document. So disparities is probably there, but not very often. So again, we've got to make as a group a decision as to what does this mean in terms of how does that sort of impact on the thermometer. If we look at the trust one, again, you see a sort of a slightly differing picture. You see diversity and equality. Inequalities is a bit further down. Equity is actually quite low. And then disparities, again, is not showing up on it. So that's sort of looking at that very sort of top level, just looking at the data in terms of those keywords and seeing what's happening. The next stage, I think, is to then look at what is actually being said around those keywords. And what we can then do is extract from the documents the key parts of the words. And as I said earlier, one of the key decisions is, do we use every type of document, or do we just focus on certain types of documents because they may be a little bit more helpful and a bit more meaningful in terms of what we're doing? But here's some examples of what some of the keywords have been looked at within the charity. So these are some selected quotes. And what I'm hoping we can do is we can then get a sense of, well, how does this play into that thermometer in terms of those levels? So when somebody talks about to address disparities in the health of a region, that's a news one. So clearly they're saying that's what we'd like to do. The question is there any evidence that they've actually done that? And that will then shift as to where they are on the temperature scale. So yes, they may be talking about it, but they may be talking about it in terms of what they want to do, but actually there's no evidence that they've been doing it. And again, that's again looking at the various different documents. If we look at the trusts, we get a similar sort of bit where some of the keywords are there, and then you get the sort of the race equality standard that they've got follows on from several recent reports that highlight disparities in employment experience and opportunities for BME staff. And so the idea then is presumably they're now going to be a little bit more proactive with that document. So again, there is this sort of several stages to this, which actually need to be guided by everybody really, more than just me as an academic looking at this, but actually to get a sense of that collaboration to say, actually, that's worthwhile, continue with that points us in the right direction, or that doesn't. So that's where we're at the moment with this. And the idea is that we then go to that next stage once we've got the group together, is to start sharing some of this information and then saying, actually, let's focus on this and let's move it on from that. And hopefully that will sort of narrow it all down. Katerina.
Great, thank you, Mark. So you heard a bit from Paula, a bit about how we envision bringing forward a community of practice together. And I think she'll agree if I say that the absolute focus of that is about being helpful in practice, not just duplicating the work of existing equity networks, although this can certainly be an opportunity for all of them to come together. And this mapping exercise, which hopefully you'll find interesting, is something we'd like to use with that group and maybe even beyond that, but just to get discussions going. And this was, as Mark was saying, this is a preview of what it can potentially offer, but it is very much flexible and adaptable to whatever that group will deem most useful. But yeah, for today, hopefully that was enough to whet your appetite. Any feedback or questions are more than welcome. And I think there's going to be certainly a discussion part at the end for the day, so after the presentation, so we can definitely talk some more about it. Thanks very much for listening.
Thanks, Katerina, Mark. I think just because there's been loads in that was really, really interesting, because I do think language generally is really important, and that, you know, you've just typified there by the scoping that you've done about, you know, disparities being in the top left-hand corner, but that's almost been, as I don't know, colleagues in OHID and NHS England might have a comment about that. I just wondered, has anybody got any comments, any questions before I move on to the next? Raise your hand or let me see you in the video. Alan, I can see you.
Yeah, I've just actually put something in the chat, but I think what you've just been talking about was really, really good. Just one little criticism, Mark. You did the deep dive, if you will, on the charities and NHS trusts. But I don't think that's where the problem lies. The problem lies with the people who have the money, i.e. the commissioners and the politicians. That's where you really want to be. Okay.
So absolutely, Alan, and I think that what we just chose for this is just to show, because I could have bored you for 2 hours with what I've done to date, and I didn't think that's necessarily what we wanted to do. I think the key bit is to almost whet your appetite to show you what you can find. And actually on my list is all the CCGs that are part of ARC. There are also the other aspects of it so there's the networks and there's that wider group of different. So it's looking at every person who's in the ARC partnership. Obviously, the further stage is actually do you then explore further out beyond that, so you can look at a wider range. So obviously it was just, here's a couple of examples. This is what we can do. And I chose charities and NHS just because I thought on a spectrum, they fitted quite opposite each other on one level. And that's hopefully what I showed. Thanks, Mark. And maybe it's a topic for our first community of practice meeting in September. I do think there will be an opportune time, notwithstanding what Alan's suggested about commissioners, the system's changing. We've got new organisations that I would suggest, having worked in an NHS space for 20 odd years, they like rebranding, new stationery in the old world. But I suspect now it'll be refreshing policies, updating specs. So that language consideration would be a really great conversation and, further discussions in a meeting in September. Thank you both. That was really, really interesting and has got my mind thinking on lots of other things, Mark, but I think you might be able to help me with your posh diagrams and your graphics. Thank you very much. Thanks people for commenting in the chat. Howard's pleased that we might be doing I don't even know, is that 1,000? I don't know how many percent that is, but he's interested in the community practice links and some of the stuff they're doing in Lancs and South Cumbria around Marmot, so that's great, and we're already connected in other ways. So yes, Howard, keep staying in touch. And then Mark from who's also involved in some of the population health management conversations in the ICS in Lancs, again is reiterated my comment about the reorganisation of some of the commissioning infrastructure around place-based commissioning, etc. So I think what we're saying is that this conversation has got some legs and some of the work that we've done has got some merit in being talked about further. So again, thank you both. Now I'd like to introduce you to Claire Selby. Claire is another ARC member of staff that's got a role and responsibility around stakeholder engagement and management. Claire, thank you.
Thanks, Paula. So as Paula says, my title is as Stakeholder and Engagement Manager across the ARC. I'm based at Lancaster University with Paula. I'm just going to share my screen to talk a little bit about the work that I do, which is mainly around the COREN, the Community Research and Engagement Network. So I'm just going to sort of talk a little bit about what that involves. But really, it's also a call to be involved. So I'll explain a little bit more about that in a moment. Can everyone see that? I can't see anyone, so can someone shout?
Yeah, we can see that, Claire.
Brilliant, thanks. So the COREN, as I explained, stands for the Community Research and Engagement Network. As we've already said, everyone likes a good acronym. So the COREN is really about bringing together key partners from across health and social care, including really crucially the VCFSE sector. And it's about mainstreaming the voice of communities into applied health research and through that more widely into health and care systems. And we all know that mainstreaming that voice is absolutely critical to achieving health equity, hence why I'm sort of talking today and why it's so important. And as I've said, I'm just going to talk briefly today about what the COREN is and what the sort of the plan is for the work over the next couple of years. But it's also really a call to be involved, because something we know is critical is the more people get involved and the more people contribute, the better work we can do. And that's from all sides, researchers, as we've talked about, commissioners, people within the NHS, within public health, but crucially, as I've said, within communities and the third sector. So the COREN's objectives, as you can see here, are to know what matters to people in local communities which health research could help improve, to ensure communities are involved in developing, creating and doing research which has the potential to impact in local places. And something I just want to say, which I think is really key, is the sort of developing side. So it's about looking at what the research priorities are. It isn't just bringing communities in once we've already had a think about the research questions and what we want to research. It's actually about looking at the priorities for research as well. The Coren also wants to create and facilitate a space for discussion and development of research, and it's also about sharing knowledge and skills around health research and how better to understand it and get involved. I am going to keep this short today because I do know there's other people who are going to talk. So I'll just talk briefly about the three main work streams that we've got within the Coren. So the first is capacity building and knowledge mobilisation. And what we want to do is build capacity with local system partners to become more involved in applied health research. And we're doing that in a number of ways. So we have a leadership group, which is made up of a series of commissioned third sector organisations from around the region, and they disseminate information for us, but they're really also key to supporting the development of the Coren and all the work that we do. We to some degree, it's about putting our money where our mouth is, and we know that we want those third sector organisations to be the ones that lead our work. We also have quite a broad ranging contact database, which is all about a place to share ideas, to exchange opportunities and information. And I will pop in the chat how you can actually join that database. It's absolutely free. There's no obligation to do anything, no time commitment, but it just means you'll hear about any opportunities like this or anything else around applied health research which might be relevant. Also in that strand, we have knowledge exchange events. So if you join up with the database, you'll hear about these. And we've had ones recently on things like citizens' juries. So they can be very practically based knowledge mobilisation events, which highlight priority topics for sort of local areas, but also the wider system. And finally, as part of that work strand, we have alternative models for public engagement. We're looking at other ways that we can engage with the public to complement that sort of applied health research going further. The second work stream you can see there is research ready and active, and this is all about recognising how we prepare sort of communities and the third sector to enable and connect knowledge to sort of support the applied research agenda. It's about harnessing knowledge and insight from the VCFSE to become more involved and to have the resources to be able to engage and influence, more importantly, applied health research. So we are looking at co-produced opportunities for public-led research. We have commissioned a survey to find out what are the barriers to becoming involved in research, and that's something that we're just looking at the moment to try and develop that further. But the final strand's also really key, and that's about community ready researchers. So we recognise it isn't just communities and VCFSE organisations that sometimes struggle to engage with research. We also realise that researchers sometimes struggle to engage with communities. They don't have the necessary skills, maybe. And there's a real willingness from all my conversations in the last 6 months in this role. There's a real willingness to want to do it better in a more sustainable and impactful way. But I think sometimes people struggle to know how to do that. So we are running community engagement courses along with the University of Glasgow in how to develop those skills, but we're also looking at things like reverse mentoring about connecting communities and researchers. So there's an awful lot of different strands to the work of the Coren, and we are always looking for more ideas, for ways to develop it further. And I think, as I say, the key thing is we want more people to get involved. That's absolutely critical to this. So what I'll do is I'll post in the chat how you can join up to the Coren, and from that you'll get continuing opportunities and events coming out to you. But if you do have any you want to know more, you want to have a further chat, then I'll also put my email address in the chat as well, and please do get in touch. Thank you.
Thanks, Claire. I'm just going back to the chat again. I think the reason we're really keen in offering these lunchtime sort of bite-sized sessions around what we do, I think because it's really difficult to work in a really complex space and everyone knowing what everyone else is doing. We regularly hear from people, I didn't know you were doing that. It would have been good if. So I think what we want to do is create through this community of practice almost a sounding board, group of friends, colleagues coming together quite regularly, but in short, sort of snappy times to sort of have some of this sharing of knowledge, this mobilising of things that we're doing. Just a couple of comments. Just in case it's not clear, the Community Research and Engagement Network is essentially the system in the room. A really good comment, Howard, about how we engage NHS folk. And I think it's fair to say in Clark, which was the previous iteration of this applied research programme, and now in ARC, it's something we recognise there's some learning in doing. But one of our rationales for this community of practice is to understand and help engage those people who don't routinely understand the research offer or what ARC is offering. In addition to research and expertise, as you've seen from the two previous presenters, we want to really engage about how you embed and mainstream health equity and health inequalities in the work that you do from a research perspective. And then also, as Claire's just alluded to, we really want to get those local system partners as part of the process about how we create research, what priorities we're aligning to, but also upscale as well. So, build learning and capacity and build understanding. So from my perspective as a person who working in ARC, it's really trying to get the message out there to non-traditional research colleagues that the ARC's more than doing an evaluation for you or supporting you with, a resource around a website about how you might, avail yourself of a PhD or an internship. We really have got a really eclectic, kaleidoscopic skill set. So it's trying to get it out there and comms it about what the offer is to lots of our member organisations across Cheshire and Mersey and Lancs and South Cumbria. So as Claire said, she's put the details in. We envisage that we have a leadership group that's led by the third sector, as Claire has mentioned, but the first sort of formal meeting, if you like, of the network is going to be September time again. So if you want to take part, you want to get involved, we will have conversations with local system partners. We are absolutely not here to be setting the agenda and then asking for support and help to drive our research interests. We really do want to sort of talk to the collaborative nature of co-production and think about who that means to get involved. So yeah, just get in touch with us. That's great. Right, next presenter is Steve Morton. Steve, are you there? I know you're saying you're having some problems dropping in and out.
Yeah, it stopped after that. So I should have just posted.
Thanks a lot, Steve.
Thanks. Thanks very much. I'm just going to start off. One of the things that Paula said just now, she said I'll introduce what OHID is, and also said we like a rebrand, and essentially that's what OHID is in some ways, but not in a simple way at all. So we are what used to be known as Public Health England, but it's not that simple. In that Public Health England was split into numerous directions. The majority of it went to the UK HSA, United Kingdom Health Security Agency, which are the ones that you'll know are doing still continue to do COVID work and monkeypox. Then some of the quality elements went to CQC, some went to NHSEI, and I'll leave that to Charlotte to describe. And then what was left was the health and wellbeing teams. So we went to do the Department of Health and Social Care in a particular office, the Office for Health Improvement and Disparities. So we are the health and wellbeing side and health inequality side of mainly facing into local authorities, whereas Charlotte's side mainly faces into the NHS in a simplified form of what we are. So I've been asked to give two presentations. The first of which is one regarding data, which is created by our colleagues in LKIS, which is the Local Knowledge Intelligence Service. So I'm just going to share this. So very briefly, I'm just going to introduce what data there is available in relation to health inequalities, which is compiled by LKIS and their partner organisations, essentially creating a collection of both national and local data, and looking at where the inequalities are, what are the causes of the inequalities, how is this having an impact, and putting them into a collection of different tools, commonly available on Fingertips, which is still available at fingertips.phe.gov.uk, which I can share afterwards. This grid here, I'm happy to share the slides with anyone, shows which tools along the top there, you'll see a list of tools that PHE used, I say PHE, LKIS has created. And down the left-hand side are some of the questions that maybe you would ask. So, for example, what are the main factors driving inequalities within the population? And you can see that the segmentation tool, the equality and care, inequalities packs help, but actually the wider determinants of health has got a full package there in relation to that question. And it's quite a good little tool that can be used to say, well, actually, how relevant is this tool for what the question that I'm asking? But it's a whole large array of tools that are available. One that most people are probably very aware of, they're looking at data. Now, I've noticed just before I did this that LKIS kind of gave me a set of Midlands or West Midlands region figures rather than Northwest, but same principle applies. So one of the tools of the Public Health Outcomes Framework, left-hand side, you'll see along there that lists the main framework targets, and you'll see how people are performing, each local authority is performing along there on that right-hand side, red, amber, green, with the actual data in there. And if you hover onto it, it'll give you more detail. It'll give you a breakdown. If you come across to these on the left-hand side, to the indicator, then that'll give you a full definition of what that indicator is. What the wide determinants of health profile is a combination of nice tables and text to provide a summary of what the position is, again, for each local authority. And I think this one's also available at an ICS level. If it isn't yet, it will be shortly. And as you can see here, we're starting to look at the built matter environment, income, crime, vulnerability, work and education in there as well. So these are the elements that are contributing towards those health inequalities. And the final quick slide showing how just to demonstrate the different types of data that's available here. Here you can have a look at the health inequalities dashboard and see how a particular area has improved, has not improved, how the gap might have widened between on particular targets. And you can choose your indicator here again. So you can have overall, or you can choose select indicators and see how performance has been over the preceding, well, since 2013, so it's rapidly approaching 9-10 years of data. So that was a quick run through the LKIS data and what's available. If anybody's got any information, and we'll certainly put you in touch with the experts in the field and help you find some of that data. It's a landmine. It's a really a mine of useful information available to all. So I'll now lead on to a bit more. What do we do in relation to health inequalities in our OHIDS team across the Northwest? I don't have to go through any of this with any of you, but just to emphasise that we are looking at the social and wider determinants of health inequalities. It's easy for us to look at access to services, but a lot of that is NHS focus. We want to start looking at, well, actually some of this is more about those wider determinants of unemployment, housing, education, but also it might be transport, which does then contribute to that access. And also a growing issue now is asylum seekers and refugees, and how that has an impact both on their health, but also on the health of everybody else in that community that they're living in. So what are we doing? On the left-hand side, I listed who attends our current health inequalities network. We've established an inequalities network during the COVID pandemic. It has evolved over various forms as things have changed in that time, but we're just re-establishing it again. So it's attended by senior managers and professionals, not just within public health, but there is a large public health lean in that group. It has met 2 monthly, and it plans to meet 2 monthly again. Online, of course, because everything's online these days. It's about information sharing, but we're trying to take the route of it being presenting evidence, whether that is from a national researcher or local researcher, policy, and how that evidence is influencing policy, normally by one of ourselves within OHID or UKHSA or NHS England, and then moving on to local practice, looking at how has that evidence affected the policy, and how is that some good examples that maybe is being used in one particular area of the Northwest that might be able to be replicated elsewhere. And on the right side, just giving you some ideas of some of the topics that we've covered over that time. At the beginning, as I said, it was COVID focus, looking at inequalities and data, some of the information I've shared with yourselves. And then looking at the health equity assessments tool, happy to help introduce that to the people at some point. Then looking at those various other groupings of people there, and having, again, we had research and speakers normally from those communities to be able, or who work with those communities, to be able to share their experiences. So as a sub product of that group, various such topics have been raised as areas of concern, which we then carried on doing some webinar and further training. So the first one's in the middle there, is a bit nondescript, is the HEAT training, health assessments training. So it provided training and support for people to learn how to carry out a health equity assessment on their work. Obviously, in some parts of the public sector, it's a mandatory requirement, but not everywhere. And it's also can be used by the third sector, so charities and like will also be able to use it. To run a short series of webinars and sessions regarding food poverty. And those food poverty sessions have, in fact, we've not been looking at food banks. We're looking far more upstream if we can. So what can we do to avoid the necessity for food banks, whilst also recognising that we will always, unfortunately, continue to need that provision. This has also led us to HEAT, the other type, HEAT, heating food, heat or eat, which is regarding the fuel poverty. And we recognised this back in August, before the prices started increasing, August last year. But it's about, our next session that we will hold will be on fuel poverty and how fuel and food poverty are intertwined. I held a session on migrant maternity services. Originally, it was focused on Afghanistan, but it was just at the time when Russia invaded Ukraine, so we included that overall as well. And then that led to another network on migrant health, which meant we had a key focus on Ukraine. We did that about a month ago. An area that we've developed quite a lot during COVID was that the Ministry of Housing, Communities and Local Government provided funding for I forgot how many local authorities, but a large number of local authorities, and a lot of those were in the Northwest, to provide community champions to support local communities to understand COVID, to know what their risks were and why the guidance was being issued the way it was, and help them be able to achieve that. It was to foster that trust between the communities and the system. To help that, because we had so many in the Northwest, we decided to establish a Northwest network to bring these together. Although our aim was to widen the remit beyond just COVID, there were so many, the focus wasn't COVID, it didn't really expand. So that funding came to an end, and then there was a bit of a pause when some of the services continued going. Some unfortunately had to close, so they'd run out of funding. And then a further 60 areas received funding from what then became the Department of Levelling Up and Housing and Communities. And that funding was allocated to different areas, and far fewer in the Northwest, with just 6 local authorities in the Northwest receiving the funding. This is the focus on vaccine uptake, but recognising that if we wanted to have this as longevity, we wanted to ensure that these community champions were able to do far more than just vaccines. And actually, just going to talk to people about vaccines isn't the right route. We're going to talk about wider health issues, wider concerns, might be housing. They need to be able to be far more multi-skilled than just talk about vaccines. So that's the approach we've taken, and that has enabled us to continue the community champions, and we'd like that to grow. This funding ends later this year. So we will be very much basing it on what people want rather than because they're getting funded to attend. So the exit strategy for DLUC and is for us to help support localities to have their own community champions networks, whether that is looking into working into hospitals, whether it's working on COVID, whether it's working on healthy weight, cardiovascular disease, whatever that might be, and to try and draw them together and share that knowledge so we can have a better signposting. And I certainly see there's opportunities here for where we can learn a lot from research as to how this is best delivered. So how do we convert research into the practice, particularly when we're looking at health inequalities, and how do we do that in our area? So drew up with a colleague the route that we actually use, and that's it follows in some ways the same as we've used for our network meetings. The research informs policy, that information is shared, it's put into practice, and the important bit which we probably don't get is that feedback back into research to be able to improve services, and that is an area I think that we in OHID can improve on, probably the whole system can improve on. We're looking at the next health inequality network meeting being based on cultural competency, and can certainly see how we can use this approach to look at cultural competency. What research is there? We know there are some training tools, but actually they're not necessarily, they're very clinical and they're not necessarily focused on communities. So how do we approach that? So we look at the policy and share that information, put it into practice, feedback, and we can, as a network, we can work with researchers as how to do that. And talking to a director of public health yesterday, we thought maybe there might be some NIHR research interests in something like that. So that's worth exploring. And finally, so how can you get involved? It'd be great to get as many people involved as possible in the Health Inequalities Network. If people would like training in how to do the health equity assessments training, we can offer that. We've got a session coming up soon. I can share the link for that. Also going to develop community of practice for those that are who are trained to deliver it and using it, because like everything else, it's useful to talk to colleagues, learn from each other. I guess that's part of that research element as well, is how is the practice going? And then if you are aware of community champions, or if you think you can have a link into the Community Champions Network, that'll be great. And let us know. And also the Health Inequality Network repeated. That should say the Migrants Health Network. If you have links with migrants, and then we would be interested in linking with Migrant Health Network. Feel free to get in touch with our team on that email address, but I'll also share my own email address in the chat in a second. So I think that's back to you. Yes.
Thanks, Steve. I'm really conscious of the time, and we've got 2 more presentations. I'm getting feedback on my voice now. I think it's absolutely recognisable that there's so much synergy and so much sort of dotting of I's and crossing of T's in only this, small meeting of 15, 16 people. So my sort of ask of everybody would be, drop people emails, get more information. We'll share the slides and the recording after this, and we will reconvene another meeting in September, because I think some of these sort of where we go from a system perspective could be sort of put in more of a systematic process, if you like. Charlotte, are you okay to share your screen and just talk a bit about NHS England and public health? Thanks.
Is that coming through, Paula?
Not to me yet. Not to me yet.
No, let's see. Oh, it looks hopeful. So while that's taking place, I'll just introduce myself. So I'm Charlotte Simpson. I'm Healthcare Public Health Consultant for NHSEI in the Northwest. And I think Steve has saved me some of the bother, really, in terms of explaining some of the history around the wrap up of PHE and kind of where colleagues went. So previously I was in the PHE Healthcare Public Health team, working kind of alongside Steve's team there. And to just say that we continue within the Northwest to operate under a single regional director of public health. So although Steve and I and our respective teams sit in different organisations, we still work quite closely together under the Office for the Regional Director. And can everyone see that now? Yes, okay, thank you. I'm seeing some nods, that's great. So I'm just going to do a quick whistle stop tour, being very mindful of the time. So I'm sure I don't need to dwell on this for too long, just in terms of the role of the NHS in terms of tackling inequalities. I think colleagues on this call will be very well versed in the unique role that the NHS can play within that, both in terms of the provision of services from birth and throughout our population's lives. Its key role in prevention and early intervention, and critically, the NHS's opportunity to create social value within communities too, recognising that NHS organisations act as a significant employer, purchaser and owner of a significant estate within many local areas and communities. And so actually there is something about recognising that the decisions that take place within the NHS can really help to shape that place in terms of the local socioeconomic conditions, which kind of brings me on to the concept of the NHS as an anchor institution, or rather the NHS organisations as anchor institutions, these being large public sector organisations that are kind of rooted within those communities, unlikely to relocate, have a significant local stake, and actually have these assets that can be used to kind of support the local area and community through some of those things that I was referring to in terms of estate, purchasing power, workforce, for example. And just in terms of context for that, I think it's just important to point out that this is in keeping with some of the national strategic direction and the creation of ICSs. This clearly provides an opportunity in terms of the ability of ICSs to contribute to local social and economic development. But it's important to kind of steer this through a health inequalities lens rather. I think the other kind of important thing for NHS organisations to recognise within that is that in some ways this may not actually be for the NHS to lead, but to act as a key partner and act alongside other partners within that community and build upon what's already there, and kind of not reinventing wheels, so to speak. And clearly there is some other opportunity in terms of alignment with kind of other strategic programmes, which kind of some examples are listed there. I think when talking about kind of health equity, it would be remiss to not at least mention the sort of greener NHS agenda within that too, and its contribution to kind of health equity. So there is a national ambition around net zero and the NHS carbon footprint, both in terms of what the NHS can directly influence and contribute towards, and kind of what is that wider influence in terms of the kind of wider carbon footprint in terms of what I suppose contributes and receives in terms of NHS activity. And just to highlight that in terms of NHS trusts and integrated care systems, there is an expectation that a green plan is in place, that ICSs should have a named net zero lead and be essentially working within place and within system partners to kind of derive action and work towards local priorities. Moving on, I'm sure many on the call have at least heard of the Core 20+5 programme, which is really the big sort of strategic programme around health inequalities nationally within the NHS. So In terms of core 20+5, what this means is a targeting of work towards the 20% most deprived in terms of the national population, as kind of measured through the index of multiple deprivation. A focus on plus groups, so these are locally defined, potentially inclusion health groups for which these populations may be subject to greater disadvantage, and actually there is a recognition that within the sort of NHS work, ICSs should focus on particular groups as kind of like locally determined. And then kind of in an even more focused way, there are 5 clinical areas that this programme is focused on. So many of these are familiar priorities that I think we've seen in terms of prevention across the years, but now there is this very targeted focus. So we've got this recognition that within maternity care, actually there's a good evidence base for ensuring the continuity of maternity care provider, and actually that this is of particular relevance to women from certain ethnic minority backgrounds, for where this connection in terms of outcome is evidence-based. There is a focus on improving annual health checks uptake for people who have serious mental illness. There is a focus within the respiratory clinical area on people with COPD, and actually increasing the uptake of COVID, flu and pneumonia vaccination within that. There is additionally a focus on early cancer diagnosis and improving that, and also kind of to round off that 5, this focus on identifying people who may have high blood pressure and actually don't know it, so doing some case finding there. And just important to say that in terms of the national programme around that, there are also other initiatives that are of relevance and interest. So there is a specific community connector programme through that. There is the development of clinical ambassadors around the core 20+5 programme. There has been the development of a national health inequalities dashboard that kind of looks at some of the key areas of focus for the NHS, including these core 20+5 areas, but also thinking about kind of inclusive restoration of services too, and also some other tools to kind of run alongside in terms of menus of interventions and that sort of thing. So just moving on, I won't dwell on this too much because I'm very conscious of time, but we've also got the NHS prevention programme that kind of originally focused on alcohol, tobacco, obesity, but in terms of that particular prevention focus within the long-term plan, that also represents a different opportunity too in terms of health equity and addressing health inequalities. And lastly, I just want to make the point that really in terms of the NHS vision for health inequalities, this is focused really around achieving exceptional quality healthcare for all through access, experience and outcomes. So although we've got this core 20+5 programme, which I think is getting a lot of traction and provides a lot of focus, it's just important to recognise that this is not the only thing that is needed and is not the only kind of piece of work underway across the NHS. We've clearly still got all the other opportunities in terms of prevention and health equity within specific sort of patient pathways, but also, like I said, that wider agenda in terms of anchors and the role of the NHS and social value. And I'm conscious we've gone over time, so I'm going to be quiet before Paula starts waving at me furiously.
No, it's been really, really helpful, and I do apologise to people for just running slightly over, but I'm sure you'll agree there's been some really interesting presentations and some discussions, especially in the chat. So thanks for keeping that populated. There's nothing worse than going to a meeting and no one puts anything in the chat, and you're just trying to sort of wring conversations out from nothing. We do have one final last presenter, last but not least, my colleague Emma Halliday. Emma. You're on mute, Emma.
Yeah, okay, thank you. So I'm not going to present any slides, but just wanted to flag up an initiative called the Public Health Intervention Responsive Studies Team, called FIRST, which is a programme, very much an NIHR funded initiative, which is very much aimed at building evidence and research from local government settings. So one of the rationales for NIHR setting this up was when they sort of reviewed their funding, they realised that, you know, a large proportion, probably around 50%, is going towards sort of healthcare, so public health, and less than 10% towards research, which was focused on improving the wider determinants of health. And as we know, that's, you know, critical in taking action in relation to health inequalities. So the first is aimed at local government, local authorities, and it involves academic teams like myself and Ben Barr at Liverpool University and other teams across the country, working with local authorities to co-produce and conduct evaluations of local authority interventions. And that can be any local authority department, as long as there's a focus on public health research questions. So the funded research can obviously help find out what the impacts these schemes have had on local inequalities and local population health. And the aim as well is to produce evidence to inform decision making within those areas, but also beyond those areas as well. So not just within the local authority. So I don't know if there are any local authorities on the call. I don't think there are, but if you have links with local authorities and think they may be interested in working with researchers to evaluate their schemes, there is currently a live call with a closing date of September the 12th, and local authorities need to apply directly. If there are local authorities in the Northwest who are interested in applying, you can certainly put them in contact with myself and Ben. We can share, Paula, you can share some contact details after the meeting, and we can sort of chat informally to people about the scheme and just give a bit of advice if that's helpful. But I think that's it. And I think I've just posted a couple of links which provide some examples of what they've funded, and also the link to the expression of interest I've just mentioned.
Thanks, Emma, and thanks to all the speakers actually who've just provided such a wide range of understanding and how we might connect into a broader system around health equity and inequalities. I do want to close it, so I won't ask for any more questions. If you've got any queries, if you're interested in getting involved, make connections through the chat, and we will share the slides as I've said, and we will go away and have a think. So this community practice idea, I think, it's got some legs. We think it has in the ARC, and I think from colleagues who've been on the call seem to think that there is some relevance to having certainly further conversations about what it might look like and how we avoid duplication, but again, align priorities through a system and applied research lens. I think lots of the things that have been talked about today are great interventions and great projects that have been delivered. I'm not sure where and talk about evidence, but I'm not sure where the research element is, certainly around community connections. Connectors, I'm really interested in learning more about that, Steve, because we do have a model for that in ARC as well. So we'll share lots of information. Keep connected. Don't wait for somebody to contact you if you've got a query. You know, we'll share a number of different email addresses. So please get in touch if you think there's some relevance. If you want a conversation out with the health equity landscape with our colleagues, again, just get in touch. Thank you for giving up your Wednesday lunchtime. I keep forgetting what day it is. Wednesday lunchtime. I hope everyone's not got too packed an afternoon full of Teams meetings, like certain individuals on this call have. Thanks, and we'll be in touch. Thank you.
Thanks, Paula.
Thanks.
Thanks, everyone. Bye.